يذهب بشوي. So this is an upper digestive endoscopy, 32 years old woman with a long history of sleeve, I think 8 years ago, then converted to bypass, and she lose a lot of weight. She was maybe more than 80 kilogram. So this is the upper esophagus. This is candidiasis infection, so we'll go in. And so we have one loop, jejunal loop, which is closed. So we have a structure here. We see it clearly here. So I won't be able to cross with my cap, so I will pull back. So we come back with the scope. It's 8.9 millimeter. When we put the cap, it will become almost 12 millimeter. So this is our stricture here. And you see it's difficult to pass here, but we will be able to go in. And we cross it here. So I remember the last endoscopy you have done. This is the ingoing loop. So I won't found any place here, maybe there. I will try to find our path here. And this is our loop. So everything is clear here, but you have this anastomotic stricture. أعطيني pince biopsy. Huh? So of course we'll put some sample from here. And this is the ingoing loop, which should be closed. And this is the end of the loop. And this is the stricture here. So I don't see the tumor here, but you see the large ulceration there. علق عليه، علق عليه، علق. هلا سكرة. So I'm almost sure I won't find anything on the biopsy, but we have to do it. So it's a long history with this case, and she will be discussed for surgery. هلا سكرة. And we did, I think the last endoscopy was 3 months ago, and it's not at all the same result. هلا سكرة. هلا سكرة. So the last endoscopy we went here, it was not so tight, and we went directly in the ongoing loop, not this one, the other one. And you see how this is the closed loop. And if we see at 6 o'clock position, this is our jejunal feeding loop, so we can cross easily and found our direction here. So, and this is what we found the last time, like not structure but an angulation here. So this is the feeding where the alimentation will come and go there. And if we pull back a little bit, we are at 40 centimeter, حط لي 40, 40 centimeter from the esophagus, and here is tight, little tight, angulation, which is closed. This is our structure there. So the food will go in this direction. And then I have to go down here. So I think we have to cut this structure and make a new one. So this is the best picture here. We have the ongoing loop which is almost closed here, and we have the ingoing here, which is enlarged. And this is the closed loop there. And you see it's really enlarged. Here we are at 45, حط 45 ترى, 45 centimeter. And if we measure the length of this loop, it begins here, حط 40. So here is our structure, 40 centimeters. So we have 5 centimeter enlarged loop. This one is the other loop, but you see, just to be able to cross, we have to go at 6 o'clock position. And we see it here clearly. This is the ingoing loop where the food should cross. And with the scope, we can cross easily. So we have no obstruction here. Avec l'anastomose biliodigestive, thus there's one way to the duodenum and the other for the food. So it's not a problem today. Don't have any ERCP to do. This is a retroflexion for the two loops. So I won't try to go more far because we are looping inside. So we come back. You have not any obstruction here. So largely opened at 6 o'clock, almost closed at 12 o'clock, and the food have to cross the 12 o'clock direction. With all this ulcer here. So usually this is an ischemic part of the gastrojejunal anastomosis, and everything is white here. This is a large ulceration, so she will of course need her surgery again. This is our stomach, and the cardia is at 36, حط 36. With large ulceration here, we see clearly. We'll check on NBA and you will see this large ulceration here. So they begin at 36 here, 35. 36, 35, and they will go until maybe they stop here, 32, 32, 32 centimeter. And this is the infection from Candida, which is at 30 tonometer.